can make the same observation, unless the person's willing to describe in enough detail the other person can do it. And then the third thing the psychopharmacology revolution was, the first was the conceptual notion that the brain had to be involved. There's no way to avoid that. The second was that it caused us to get serious about diagnosing people in a way we had never done before, integrated reliability. And the final thing is it stimulated neuroscience. And neuroscience, brain science, is now the second fastest growing area in all of science. Second fastest in all of science, not just all biological, not just all medical, all science, period. And the reason that neuroscience got started was the observations that drugs were affecting people. Prior to that, neuroscience was wiring diagrams. It was neuroanatomy. That's what neuroscience was. Functional neuroscience, trying to understand the big challenge, and the reason that Julie Axelrod, my friend and colleague at NIMH, won the Nobel Prize, was that he tried to figure out how did antidepressants actually work. And he made a series of discoveries that were fundamental on neurotransmission, receptors, reuptake, all the rest of it. And all of that was simply trying to find out how antidepressants work. In fact, if you go back in the history of medicine, you find that most fundamental new directions in medicine, most fundamental new departures where new fields develop, don't start in somebody's laboratory. They start with a clinical observation. They start with some alert clinician noticing something that hadn't been thought of. And of course, discovery means going after things that nobody thought of before, because if you just rediscover what everyone already knows, if you get immediate agreement on your discovery, it's not a very interesting discovery. My gosh, this drug had a specific effect. How could that work? And that set that whole thing in motion. I'm very worried about current concepts of guideline-driven medicine, where a group of people will sit on a committee and come up with guidelines and say, this is what we'll pay for. If you do it this way, we'll pay for it. So-called evidence-based medicine. There's nothing wrong with the intention to make it guideline-driven, but what happens to innovation then? What happens to the person who has a notion that's not in the guidelines? Because guidelines are yesterday's medicine by definition. Guidelines are always out of date the minute they're issued, because it takes maybe a year or two to get a guideline published. Guidelines are also the lowest common denominator, because if you've ever worked in a committee, everyone tries to come to agreement. So nothing that sticks out there gets in. And in fact, the more you know about the illness, the more experience you have about dealing, let's say, with bipolar illness, the more difficult it is to stick within guidelines, because guidelines are general averages for the average clinician, for the average patient. And there's no such thing as the average patient. Everybody has unique differences. And I'm concerned now that evidence-based medicine, now that it's getting into the equation of who pays, or what's paid for, that's a dangerous trend. Because if clinicians feel a financial incentive to practice only what some committee said is appropriate, and said it 2 years ago, where are we going to get people trying new things that then become the raw material for researchers to figure out if that is real? Not that everything the clinician says he thinks he observed is going to be real, and it's up to researchers to separate the wheat from the chaff. But without that creative energy out there, with people free to do individual different things, you're not going to have the grist for the mill of the researchers to know what to follow up on and evaluate. Another point about the misuse of evidence-based medicine is that you often see this in the press, some young PhD in public health will write a review article, usually in either JAMA or the New England Journal of Medicine, that will review an area of research looking at modern research studies and say that this treatment that doctors use a lot, really we can't find evidence that it works. Now, the young PhD, I expect, is naive and doesn't know some of the realities of clinical medicine, but I can't really forgive the editors who let that kind of stuff get in there, because it should be obvious to anybody that any old drug is difficult to show that it still works, because it still works. That is to say, if any of you had an illness and you were on an old drug and you were responding well to it, you have no incentive, and it's not even ethical for me to recruit you into a study to try something new. So studies that we do in research get patients who are not doing as well in what's out there. That means that